Welcome to the Onvida Health Base Hospital EMS Treatment Guidelines video tutorial series. This is Dr. Franco Castromarin, and you're watching Part 7, Toxicology and Environmental. This video is intended for any EMS provider who's operating within Yuma County with Onvida Health, formerly known as Yuma Regional Medical Center, as your base hospital and administrative medical direction. Please confirm with your chain of command if you are not sure. The primary objective for this Part 7 video is to go over in detail every page of the treatment guidelines in the toxicology and environmental section. The setup is simple. When I'm comparing a new guideline to an older version from the YRMC protocols on the same or similar topic, the new version will always appear on the right of the screen and the old version will be on the left. They will be labeled in the top left corner of every page, new versus old. Having the old material available for comparison will help you build familiarity and comfort with this new content. Along the way, I'll point out important details on each guideline and share some effective teaching pearls. Remember, you will always have access to this training content, and you can come back to review it at any time at your own pace as often as you'd like. I encourage you to have your mobile device out and use it to follow along as you watch these videos. One of the advantages to this rollout is that we are using the same mobile app vendor called Acid Remap to host our guideline document, so much of the app navigation should be familiar to you already. As you may know from using the Acid Remap mobile app, there's a way to make your own notes. Feel free to use this function frequently as you pick up useful teaching pearls from these training videos. The first guideline in this section is called Poisoning and Overdose Universal Care. This page is actually a consolidation. It replaces and combines the key elements from 3 separate pages in the old YRMC material: the Universal Toxicological Response, the Adult Poisoning and Overdose, as well as the Pediatric Poisoning and Overdose protocols. The new version is an expanded and much more refined approach to these calls. As with the Universal Care Guideline that we talked about back in the General Medical section on a different video, the Poisoning and Overdose Universal Care Guideline sets the stage for all toxicology and environmental emergencies. Whether it's a stimulant overdose, opioid poisoning, pesticide exposure, or a hydrocarbon inhalation, this is the core approach that we're going to build from. Other guideline pages will link back to this page, so we don't have to repeat basic information every time. The opening section of the page explains that poisoning can happen through ingestion, inhalation, injection, or skin contact. That's consistent with the YRMC language, and we keep that orientation here. The source might be a medication or a household product, maybe a type of gas, venom, or industrial chemical. This page will help you organize your initial assessment and early care steps, no matter what kind of exposure you're dealing with. Let's begin with reviewing some familiar elements. The YRMC version emphasized provider safety, trying to identify the agent, and involving poison control early. You'll see all of those carried forward here, still foundational, still emphasized. We continue to stress safe entry into the scene, personal protective equipment, collecting information about the agent involved, and documenting recommendations from the Poison and Drug Information Center. Those core expectations don't change. But the Onvida version adds a lot more structure and detail to help you. At the top of the page, we've included a list of hyperlinks to other guidelines that cover specific agents. Things like opioids, cyanide, acetylcholinesterase inhibitors, stimulants, hydrocarbons, and several more. This makes it faster to jump around between pages without having to search or scroll. Right below that, you'll also find quick access to 2 key resources that are available to you 24 hours a day, 7 days a week: the Arizona Opioid Assistance and Referral Line, as well as the Regional Poison and Drug Information Center. These numbers are shown right here, front and center, for easy reference in the field. Please note that the phone number to the Banner Regional Poison and Drug Information Center is updated throughout this document and correct on this new version. There's also a clear caution statement. All suicidal patients must be transported to an appropriate receiving facility. If a suicidal patient refuses care, law enforcement may be needed to initiate a mental health hold. That's a best practice clarification that aligns with current regional standards and avoids legal ambiguity in the field. Moving to the EMT section, we include all of the standard actions, such as ensuring scene safety. Hazards are common on these calls, including airborne toxins and dangerous environments. It's important to make sure you're using appropriate PPE, including respiratory protection if necessary. Once your safety is ensured, move the patient away from the exposure to either a cold zone or warm zone as needed. Remove contaminated or wet clothing. Begin skin decontamination if indicated, and make sure to prevent hypothermia if you are decontaminating with water. Those points build directly on the old Universal Toxicological Response and both of the YRMC overdose pages. We've been able to organize them more clearly, and we've assigned them by scope of practice. The guideline then walks you through the Universal Care Bundle, monitoring pulse oximetry, supporting the airway using the least invasive method possible, and maintaining normal body temperature. In pediatric patients, BLS level airway support is often all that you're going to need. That aligns with prior practice, but the Onvida version adds structure and consistency. Document and collect any medications or toxic products involved. Bring the containers with you or take pictures. With all digital imaging, make sure you're only using an agency-owned device. This instruction builds on the YRMC guidance to collect containers and document exposures, but adds a privacy safeguard regarding image capture. The guideline also reinforces identifying the intoxicating agent based on history, toxidrome, or environmental context. This language gives EMTs a framework when the substance isn't immediately known. As you know, one of the most important enhancements to the new guidelines is inclusion of pediatric care elements on the same page rather than being in a separate guideline as they were before. There are a few pediatric elements to keep in mind here. Children often show symptoms faster than adults due to higher absorption rates. And during wet decontamination, infants can be very slippery. Make sure you're using extra caution to avoid dropping a patient. For paramedics, the Onvida version offers more actionable detail than the old YRMC page. Establish IV or IO access. Give a fluid bolus of 20 milliliters per kilogram if there's signs of hypoperfusion. Same dose for all ages. We include explicit prompts to start continuous end-tidal CO2 and cardiac monitoring and obtain a 12-lead ECG. Some important things to look for on the 12-lead when it comes to poisoning or overdose patients includes rates that are too fast or too slow, and also checking closely for QRS widening or QT prolongation. These specific prompts help sharpen clinical focus during field interpretation. The old version really lacks detail in this area other than monitor ECG. Point of care testing is now mentioned if applicable. For example, carbon monoxide or cyanide testing. This acknowledges that some agencies now carry portable blood analysis tools. If the patient is agitated, delirious, hyperthermic, or tachycardic, pharmacological sedation is definitely appropriate. The Onvida guideline refers you to the agitated, violent patient behavioral emergency page for dosing guidance. Again, that's a helpful cross-reference that wasn't in the YRMC version. Now you're going to notice that two treatments listed in the old YRMC poisoning pages are no longer included here. Sodium bicarbonate for suspected tricyclic antidepressant overdose, as well as activated charcoal for general ingestions. Both have been intentionally omitted from the Onvida guideline. Sodium bicarbonate still has a role for managing wide QRS or ventricular arrhythmias in confirmed TCA overdose, but in the pre-hospital setting, those cases are rare and really difficult to identify confidently. The updated approach defers this decision to the receiving facility. As for activated charcoal, its use has been widely discouraged for many years in emergency medicine due to the relatively low benefit as well as frequent contraindications. It's often more harmful than helpful when given without definitive substance timing or airway protection. By removing these from the standard protocol, Onvida aligns with modern EMS best practices and shifts the focus toward airway management, toxidrome recognition, and safe transport. To summarize, this new Universal Care Guideline replaces and upgrades 3 separate YRMC pages into one unified format. It preserves the familiar steps, introduces helpful tools and resources, and streamlines the care sequence for both adult and pediatric patients. Once your universal care is underway, you can then pivot to the agent-specific guideline that matches your findings, and we'll continue to those next. This next page is going to be new for you. It's the guideline for stimulant toxicity, and it covers substances like cocaine, amphetamines, MDMA or ecstasy, PCP, bath salts, etc. We've never had a dedicated stimulant toxicity page before, so everything here is new content, but most of it should feel familiar if you've treated patients like this in the field. Start with universal care as always, with an added hyperlink again to the poison/overdose universal care page that we just covered if needed. For EMTs, the guideline reminds you to think broadly about how these patients can present. Don't forget to check for signs of trauma, including self-inflicted injuries. Ask specifically about chest pain or shortness of breath, as these are common complaints in patients using cocaine or methamphetamine, and they may indicate serious cardiac complications. If your patient is agitated, aggressive, or confused, you can go to the Agitated, Combative, or Violent Patient Guideline for management steps as well as medication options. If they're overheated, reference the Hyperthermia Heat Exposure page. And if they're reporting any chest pain or show any ECG changes, you'll be directed to the Chest Pain/Acute Coronary Syndrome Guideline. The pediatric section adds two important elements. First, children can have coronary vasospasm from cocaine exposure, which may cause acute coronary syndrome even in the absence of underlying coronary artery disease. Second, seizures are common in pediatric stimulant poisonings, so stay alert to that possibility. For paramedics, vascular access followed by fluid resuscitation are the first major steps. Administer fluids as needed for hemodynamic instability, dehydration, or hyperthermia. This is a supportive measure that addresses multiple possible complications of stimulant use. Next, initiate continuous cardiac monitoring and assess the rhythm strip for any arrhythmias. If you see a concerning tachycardia, you can refer to the Tachycardia with a Pulse page for treatment guidance. Make sure to acquire a 12-lead and transmit it when indicated. Stimulants have a way of unmasking underlying cardiac disease or triggering ischemia, so it's worth being thorough here, even if the patient appears otherwise young or healthy. You'll also want to know that capnography. End-tidal CO2 monitoring is required to detect respiratory decompensation, especially in patients who are altered or have taken unknown combinations of substances. Remember, more and more commonly, fentanyl is getting mixed with stimulants, and users are not aware until it's too late. That's the overview for stimulant toxicity. This page pulls together the major issues that you might encounter with these types of drugs, such as agitation, hyperthermia, cardiac complications, as well as dehydration. Here's another new page. It's the Opioid Poisoning and Overdose Guideline, and for the first time, it gives us a dedicated, structured approach to one of the most common and high-profile toxicologic emergencies in EMS. There wasn't a standalone opioid guideline in the YRMC protocols. Previously, opioid toxicity was addressed only as one possible branch within a broader altered neurologic function page. That older approach simply listed naloxone as an option when altered mental status was suspected to be a result of opioid toxicity. In contrast, the new Onvida guideline consolidates and expands that content into a focused page that addresses all aspects of opioid toxicity, recognizing it, providing airway support, the naloxone dosing, what happens with recurrent symptoms, field documentation, and then finally helping patients access public health resources. It brings clarity and depth to what has unfortunately become a routine EMS call. This page applies to patients of all ages who are known or suspected to have used opioids. It explicitly excludes patients whose altered mental status is clearly due to something else like head trauma, hypoglycemia, or hypoxia. The guideline defines acute opioid toxicity as some combination of these signs: limpness of the body, cyanosis, obviously respiratory arrest or compromise such as choking or gurgling, unresponsiveness, pinpoint pupils, and cold, clammy skin. These findings help distinguish opioid overdose from other causes of altered mental status, giving crews a simple checklist to guide their field impression. Importantly, the guideline reminds us that naloxone only reverses opioid-induced respiratory depression. At the time this video is being recorded, naloxone is not felt to be helpful or indicated in cardiac arrest, but this is a topic still being studied. Furthermore, naloxone shouldn't be given to patients who are awake, breathing adequately, or arousable with minimal stimulation. Administering naloxone in those cases could precipitate a severe withdrawal and worsen agitation or actually induce vomiting. In other words, it just isn't helpful to administer naloxone to a patient only on the basis of pinpoint pupils or clammy skin when they are otherwise awake, talking, following commands, and breathing normally. This page also adds an important safety note. With fentanyl and other synthetic opioids increasingly found in the illicit drug supply, patients may not respond predictably to naloxone, or they may have co-exposures to other substances. That's why the guideline emphasizes traditional airway management and respiratory support while you wait for naloxone to take effect, or in case you don't get the improvement you expect. Moving to the EMT section, as always, start with universal care, and again, we have an added hyperlink to the poisoning and overdose universal care page if needed. Then, if the patient shows signs of acute opioid toxicity, prioritize your resuscitation, open that airway, provide those ventilations, and then think about administering naloxone intranasally if you have it available and you've been trained under the STR process. The recommended intranasal dose is 4 milligrams in a single spray delivered into one nostril. It can be repeated as needed. EMTs are also advised to document what the patient actually took. For example, if it was a pharmaceutical-grade opioid like oxycodone, try to determine if it was an immediate versus sustained release, what quantity, and when it was consumed. Bring medication containers to the hospital or photograph them using an agency-owned device only. Consider other causes of altered mental status, such as trauma, low blood sugar, hypoxia, and shock, and address those accordingly. Monitor closely for recurrent respiratory depression, which is common with these longer-acting opioids. As you likely have observed, patients often experience a rapid and full recovery after treatment with naloxone. Even so, do your best to encourage them to come to the emergency department for a more thorough evaluation. If a patient ultimately declines transport, regardless of whether naloxone was administered, the guideline recommends calling the Arizona Opioid Assistance and Referral Hotline to help arrange recovery resources for the patient. If available from your agency, offer a leave-behind naloxone kit as part of public health outreach. For paramedics, naloxone is typically given IV or IO, especially when the patient is more critically ill. The dose range is 0.4 to 2 milligrams, which can be repeated as needed, but with the caution that higher or repeated doses does increase the risk of pretty severe withdrawal. Make sure to support that airway and breathing throughout the call. Establish vascular access as needed and refer to the shock guideline if the patient is hemodynamically unstable. For pediatric patients, the recommended naloxone dose is 0.1 milligram per kilogram, again with repeat dosing if necessary. So in summary, this new page replaces the very limited generic opioid information contained in the Altered Mental Status Guideline and adds much more structure and value. It supports both airway-first care as well as evidence-based naloxone use. It includes resources for patients, which is very important, especially those who end up opting out of transport. And it brings opioid overdose treatment in line with current public health best practice. The next page is the updated cyanide poisoning guideline. This is going to replace and combine the two older YRMC guidelines that were titled Cyanide Poisoning Option 1 as well as Option 2. In the YRMC version, the treatment path you followed depended on which antidote was available, either hydroxycobalamin or the combination of amyl nitrite, sodium nitrite, and sodium thiosulfate. That split page design is no longer needed. The new Onvida guideline presents all the approved treatments in one place with better direction and scope-specific instructions. The page begins by identifying common scenarios where cyanide exposure could occur. Think firefighting, industrial accidents, suicide attempts, or chemical warfare. The signs and symptoms are listed, including arrhythmias, seizures, apnea, cardiovascular collapse. These are all carried over from the prior guidelines, so they should feel familiar. In the EMT section, the instructions are very straightforward and they're unchanged in their underlying principle. Make sure to assure your scene safety, use proper PPE, including SCBA, if the environment calls for that. Remove the patient from the environment, apply high-flow oxygen, either through non-rebreather or assisted ventilations through a BVM. Start pulse oximetry, initiate universal care, make sure to expose the patient so you can evaluate thoroughly, and then recover to avoid hypothermia. Finally, make sure to contact the Regional Poison and Drug Information Center if needed. Now moving on to the paramedic section, the most important change is the clear prioritization of hydroxycobalamin, also known as the cyano kit. It is now listed first as the preferred treatment, reflecting national recommendations due to its favorable safety profile, as well as its compatibility with carbon monoxide co-exposure. The dosing is consistent with the old version, 5 grams IV or IO over 15 minutes for adults. But now we've also added pediatric dosing, 70 milligrams per kilogram, up to a max of 5 grams, which matches the adult dose. If you can, try to get a pre-treatment blood sample. Below that, you'll see that the sodium nitrite and sodium thiosulfate options still appear, but notice that the amyl nitrate is no longer included. Also, there's another major change here. These medications are now labeled for tox paramedic use only, meaning they're reserved for paramedics who've completed specialty toxicology training and have been authorized by the agency or base hospital to carry and administer these drugs. Note the hard stop comment that sodium nitrite should not be given if the patient is hypotensive or hypoxemic. Pediatric dosing is included in line, just as with the old protocols, and there's a reminder that if symptoms reoccur, the nitrite and thiosulfate combination may be repeated at half the original dose. Please note that the pediatric doses are now expressed first in milligrams per kilogram instead of the milliliters per kilogram in the old version. That's very important. So by consolidating all these treatment options into one page, this updated guideline eliminates confusion in the field and hopefully simplifies access to that dosing information. It also reflects current national trends by elevating that hydroxycobalamin cyano kit as your first-line status and restricting nitrite and thiosulfate administration to specially credentialed providers only. Crews still receive the same treatment options, but now with improved structure, safety guardrails, and clarity. This next page covers carbon monoxide and smoke inhalation. If it looks familiar, that's because it is. This content was recently updated in the old YRMC guidelines using the same clinical source material that informed the new Onvida version. That means the two pages are nearly identical in layout, content, as well as treatment approach. There's nothing new to learn here, just a reaffirmation of what's already in practice, updated to all of our new visual formatting. The guideline applies to all suspected or confirmed carbon monoxide exposures, including house fires, propane heaters, combustion engines, and enclosed recreational smoking environments. It encourages the use of scene monitoring tools when available, such as commercial carbon monoxide detectors or transcutaneous CO monitors, since that information can be helpful for the hospital team. Signs and symptoms are broken down into mild, moderate, and severe. These include headache, nausea, fatigue, and vertigo on the mild end, as well as altered mental status, chest pain, seizures, or cardiac arrest in more severe cases. That classification and the associated carboxyhemoglobin ranges are unchanged from the YRMC version. For EMTs, we put the focus on scene safety, appropriate PPE, again removing the patient from the source, high flow oxygen administration, pulse oximetry monitoring, and inquiring about other possibly exposed individuals. Paramedics are expected to start cardiac and end tidal CO2 monitoring, obtain and transmitting ECG, as well as drawing a blood sample early for hospital testing and verification if possible. The carboxyhemoglobin chart near the bottom of the page is the same as in the prior version and serves as a reference for likely symptoms based on severity. In short, this page reinforces what you already know on the topic, no changes in treatment or expectations, just a consistent evidence-based protocol across both legacy and updated systems. This next page is all new. It's the Dermal Chemical Burns Guideline, and it covers chemical exposures that damage the skin, eyes, or mucous membranes. Until now, this content was not really available in a dedicated EMS treatment page on the old YRMC protocols. What you'll see here is a clear and practical approach to managing this type of exposure, from initial decontamination to symptom control and cardiac monitoring. Start by ensuring scene safety. Chemical exposure scenes can carry risks to providers, as you know, especially with volatile or airborne agents. Use appropriate PPE and remove the patient's contaminated clothing placing it in impermeable bags if possible to prevent secondary exposure. If the chemical is dry or powder-based, brush it off before using any water. For liquids, blot first and then flush with copious amounts of tepid water or saline. This applies to skin, mucous membranes, and the eyes. If you're decontaminating a large surface area, take measures to prevent hypothermia. EMTs are also instructed to estimate the total body surface area involved using standard burn charts and to begin irrigation right away, especially for eye exposures. For skin burns, if the substance is known to be hydrofluoric acid, the EMT can apply calcium gluconate 2.5% topical gel after 3 minutes of water irrigation. Paramedics take note this step also is going to apply to you. The paramedic section expands care with IV or IO fluid resuscitation for circulatory support as well as pain control, including referral to the management of acute pain guideline. When the eyes are involved, you're authorized to use proparacaine or tetracaine drops, 1 to 2 drops on each eye, and you can repeat that as often as you need to. After the patient is comfortable, begin continuous eye irrigation with water or saline and use a commercial irrigation device if available. Hydrofluoric acid exposures deserve very special attention. If it's a cutaneous exposure, paramedics will also apply calcium gluconate gel if it's not already done. More critically, the patient is at high risk for electrolyte shifts, especially hyperkalemia and hypocalcemia, both of which can cause life-threatening arrhythmias. For that reason, both adult and pediatric patients with suspected hydrofluoric acid exposure should be placed on a continuous cardiac monitor. If you see ECG changes suggestive of hyperkalemia, make sure to start IV and IO fluids and treat with calcium gluconate or calcium chloride, and then add albuterol by nebulizer. For pediatrics, you use the same approach, but we have a proper weight-based dosing. This guideline fills an important gap in the previous treatment framework, especially for industrial, agricultural, and lab-related injuries. It supports early field decontamination, anticipates complications from specific high-risk substances like hydrofluoric acid, and coordinates care across the EMT and paramedic levels. This next page covers acetylcholinesterase inhibitor poisoning, which includes nerve agents, organophosphates, and carbamates. These exposures are rare, but they are high risk, and this guideline gives clear, updated instructions for what to do when you encounter them. You may remember this content from the older YRMC document titled Organophosphates Nerve Agent Exposure. The new version still includes all the essential information but improves clarity and streamlines care. Let's start with signs and symptoms. The old guideline used the classic sludge mnemonic: salivation, lacrimation, urination, diarrhea, GI distress, and emesis. The Onvida version replaces that with dumbbells, a more widely taught and more complete toxidrome mnemonic. This stands for diarrhea, urination, meiosis, which is tight constricted pupils, muscle weakness, bronchospasm and bronchorrhea, bradycardia, emesis, lacrimation and laryngospasm, lethargy, and then finally salivation, sweating, and seizures. This covers both muscarinic and nicotinic symptoms, and it's a small but meaningful update to modernize provider education. EMTs are reminded to wear appropriate PPE and start universal care with special attention to airway and neurologic assessment. Decontamination is emphasized again, removing clothing and washing the skin with soap and water. As always, with wet decontamination, do your best to prevent hypothermia. In the paramedic section, the atropine dosing is now simplified. The previous version used a dose range between 2 to 5 milligrams for adults and then 0.05 milligrams per kilogram for pediatrics. The new version uses a fixed adult dose of 2 milligrams, and then the pediatric dose is now doubled to 0.1 milligrams per kilogram with a max of 2 milligrams to match the adult dose. Both can be repeated at 2 times the original dose every 3 to 5 minutes based on clinical response. Importantly, the criteria for repeat dosing have been simplified. The old guideline included GI symptoms like vomiting and diarrhea. The new version focuses on the respiratory involvement. You're looking for resolution of the bronchorrhea or the wet secretions in the lung and chest, improved vital signs, and better ventilation compliance. This shifts the emphasis to practical field assessments, which are more objective and relevant to airway management. The pralidoxime or 2-PAM section remains mostly unchanged, but is now clearly marked as a tox paramedic only, reinforcing that it's reserved for specially trained personnel. Dosing for both adults and pediatrics matches the old guideline. For severe cases, a 2-PAM infusion may be considered after the initial bolus. Notice that there's also a pediatric-specific warning retained from the old YRMC version under 2-PAM. Sudden apnea can occur in infants, and that usually happens after the second dose. For patients with seizures, the guideline now includes a hyperlink to the seizures page for medication guidance. In practice, this means you'll be using midazolam or lorazepam. Diazepam has been removed, as you know, from the drug box entirely, given the superior options available with current formulations and routes. So to summarize, this updated guideline modernizes the toxidrome mnemonic, we're now using dumbbells, uses a fixed atropine dosing with simplified repeat criteria, highlights an airway-focused reassessment, retires diazepam in favor of better options, and keeps all the critical antidote protocols in place while clarifying which require ToxMedic certification. This is a high-risk but low-frequency guideline. It's now more straightforward, more readable, and more aligned with national toxicology recommendations. This next page is entirely new. It's the guideline for radiation exposure, which covers both external contamination and internal exposure to radioactive material. Now, most EMS providers won't encounter this often, but when they do, it's usually in the setting of either industrial accidents, transport mishaps, or terror-related events. Patients receiving radiation therapy at home, especially radioactive iodine, can also present to EMS with minor exposure risks. The guideline starts with a clear reminder. Most patients will be asymptomatic at first. When symptoms do occur, they're typically delayed by hours or even days. Early nausea and vomiting could indicate a more serious exposure, but they're the exception, not the rule. Standard body fluid precautions remain essential, especially for patients recently treated with systemic radiation. These patients can emit small amounts of radiation through urine, vomit, or other secretions, which could pose a minimal exposure risk to caregivers. But here's the key point. Standard EMS PPE won't protect you from penetrating radiation. It only helps prevent surface contamination. To limit your own exposure, follow the basic radiation safety principles of time, distance, and shielding. Standard turnout gear or disposable coveralls can provide reasonable protection from contamination, but not from the radiation source itself. The EMT section gives detailed practical guidance, including ensuring scene safety, wearing PPE, starting with universal care, including body substance isolation and decontamination steps. Use wet wipes, gauze, or soap and water to clean exposed skin. If possible, collect wastewater and place it in labeled radioactive waste containers. If the exposure is inhaled, administer oxygen and provide airway support using the least invasive method necessary, especially in pediatric patients. One important clinical point: trauma always comes first. The guideline makes it clear that radiation decontamination should never delay stabilization of life or limb-threatening injuries. If the patient is contaminated and also has a traumatic injury, triage and manage according to the traumatic injuries first. Whenever possible, decontaminate the patient and their wounds before they reach the trauma bay, ideally on scene or just outside of the emergency department. For severe radiation exposures, make sure to consider direct transport to a burn center. These facilities are often best equipped for supportive care as well as decontamination coordination. The paramedic section is intentionally left blank here. That's because the priorities here are all scene safety, decontamination, airway management, and supportive care, all of which fall within the EMT scope of practice. This new radiation exposure page fills a gap that we had in the old YRMC guidelines. It's straightforward, focused on practical actions, and aligns with national recommendations for low-frequency, high-risk exposures. This next page covers hydrogen sulfide poisoning, a rare but high-risk exposure most likely to occur in sewage systems, pulp and paper plants, petroleum refining, or confined space industrial work. This guideline replaces the older sulfide poisoning page from the YRMC document and offers an updated and more streamlined approach. Much of the core content remains the same. The new version retains the hallmark symptoms you've seen before, including rotten egg odor, upper airway irritation, pulmonary edema, especially late onset, sudden collapse, sometimes of more than one victim, especially in enclosed spaces. It also reinforces a critical point. While hydrogen sulfide has a strong odor at very low concentrations, you can experience olfactory fatigue pretty quickly. This means that patients or you as a rescuer may lose the ability to detect the odor even as toxic exposure continues. Both versions list similar environmental sources: decaying organic matter, sewage, hot asphalt fumes, mining, petroleum work, and septic systems. The new Onvida version improves on a few key points. It emphasizes scene safety and PPE with clear direction to use SCBA in low oxygen environments. It updates the Poison Center contact information to the national 800 number, replacing the old phone number in the YRMC version. It encourages early pulse oximetry, oxygen therapy, and patient removal from the exposure environment, and it adds a reminder to assess for traumatic injury from falls or syncope, something particularly important in confined space rescues. In the paramedic section, the focus remains on cardiac and end-tidal CO2 monitoring with 12-lead ECG acquisition as appropriate. And you'll notice one major difference: the Onvida version does not include amyl nitrate or sodium nitrite. These medications were listed in the old guideline, but their use in hydrogen sulfide poisoning is controversial, poorly supported, and generally not recommended by toxicologists in the modern era, especially in single patient scenarios. They carry risks of hypotension and methemoglobinemia, and their benefits uncertain unless the diagnosis is extremely clear and the exposure is very severe. By removing these treatments, the Onvida guideline aligns with current recommendations and avoids unnecessary harm from empiric antidote use. In short, this page reinforces field priorities: scene safety, high flow oxygen, airway support, monitoring, and consultation with the Poison Center if needed. It keeps the guidelines simple, evidence-based, and practical. This page is all new. It's the Bites and Envenomations Guideline. It will cover stings, bites, and toxin exposures from terrestrial and marine animals, arthropods, and insects. Whether the source is a rattlesnake, scorpion, spider, or jellyfish, this page gives us a unified approach to managing these cases in the field. The key message is this: there are very few field interventions that will reverse or neutralize envenomation. Your job is to recognize potentially serious exposures, manage the symptoms, and transport the patient to a hospital with access to the appropriate antivenom or antitoxin when applicable. As always, start with universal care and add targeted monitoring and support based on the patient's presentation. In the EMT section, you're instructed to check a glucose, especially in patients with altered mental status or seizure. Monitor pulse oximetry for respiratory decline, manage pain conservatively using clean dressings or limb support when appropriate, refer to shock, seizures, or allergic reaction/anaphylaxis guidelines as needed. There are also several strong cautions clearly listed. Do not apply tourniquets, cold packs, or make any incisions on the skin, and do not attempt any suction. These are still occasionally seen in the field, but have been clearly shown to worsen outcomes and offer no benefit. For rattlesnake bites, the directive is simple: transport all patients to the hospital. Even if symptoms are mild at first, systemic effects can progress unpredictably. Do not rely on physical exam findings to rule out a significant envenomation. The guideline also notes that certain envenomations, like those from scorpions, black widow spiders, and rattlesnakes, may have specific antivenoms available. If you suspect one of these, consider transporting to a facility with access to that resource. You can confirm availability by calling the Regional Poison and Drug Information Center ahead of time. The paramedic section adds the following. First, consider a 20 milliliter per kilogram fluid bolus for hypotension or systemic signs. Start cardiac and end-tidal CO2 monitoring and obtain a 12-lead ECG. Provide pain control. And here, fentanyl is going to be preferred over morphine because it causes less histamine release, reducing risk of compounding hypotension or other negative effects. If you encounter hypotension that persists despite fluids, you can refer to the shock guideline here. Also, if you're considering IV medication to treat a scorpion sting for either pain or severe agitation, do not use ketamine. it may worsen neurotoxicity and complicate the neurologic assessment. Stick with either fentanyl or midazolam, depending on what you're trying to treat. You can always contact online medical direction for more advice. In summary, this page gives us field-ready, toxin-agnostic structure for evaluating and transporting patients exposed to venomous bites and stings. It reinforces evidence-based practices, removes outdated interventions, and connects crews directly to the Poison Center for expert guidance. This next page is also new, and for EMS providers like you who work in Arizona, it's one of the most important additions in the entire treatment guideline set. This is the hyperthermia and heat exposure guideline, and it gives us a very structured, evidence-based approach to managing heat illness in a region that regularly experiences some of the highest temperatures in the country. The guideline breaks heat illness into 3 categories. Heat cramps, which usually involve painful leg or abdominal muscle cramps, but body temperature remains normal. Heat exhaustion, which is gradual onset of tachycardia, hypotension, elevated body temperature, nausea, vomiting, and cramping. This results from combined sweat and water loss and then progresses to heat stroke if not treated appropriately. The third and final stage is heat stroke, defined as a temperature over 104 degrees, or essentially environmental heat illness with resulting altered mental status. This is a life-threatening emergency caused by complete failure of the body's heat regulatory systems. This page also clarifies what isn't covered here. This is not a place for managing fever from infections, malignant hyperthermia, or neuroleptic malignant syndrome. Those are separate conditions with different treatment strategies. In particular, externally cooling patients with fever is not only not effective, but very unpleasant to the patient as well. In the EMT section, start with universal care, and then make sure to move the patient quickly and safely to a shaded or cool area. Remove as much clothing as practical. If they're alert, offer small sips of cool fluids. If they're altered, check a blood glucose and protect the airway. Watch closely for vomiting and for seizures. If the core temperature is over 104 degrees or if the patient is altered, initiate active cooling right away. The most effective, evidence-based method to cool a patient down is an ice bath immersion. Some larger EMS agencies have developed protocols to do this using a body bag filled with ice and water, and at the time of this video recording, you might see a similar process coming to your agency within the next few months. Otherwise, such a process may already have been started on scene. If you see that it has by either an event medic, athletic trainer, or other military personnel, continue it. You can discontinue the ice bath once the patient's core temperature hits 101 degrees. If you cannot do this kind of immersion, there are other options. You can rotate ice water soaked towels or sheets. You can mist the skin with tepid water and then fan the patient continuously. You could also use truncal ice packs, possibly as a backup, although these are less effective than evaporative methods. A paramedic can add circulatory support and monitoring, so make sure you're starting an IV or IO. You're giving the patient 20 milliliters per kilogram fluid bolus, using cooled IV fluids if they're available. And then once the patient starts to stabilize, you can reduce down to 10 milliliter per kilogram boluses as needed. Initiate continuous cardiac monitoring. Make sure to record vitals and mental status and stay alert for arrhythmias or other signs of cardiovascular collapse. If the patient starts having seizures, you can follow the seizures guideline. Otherwise, this guideline is especially relevant for elderly patients with broken air conditioning units, outdoor workers, athletes, unhoused populations, and anyone left in enclosed vehicles. It also reinforces the role EMS plays in early field cooling, which can significantly improve outcomes in severe heat stroke. By recognizing the progression of illness from heat exhaustion up to heat stroke and treating aggressively when you start seeing those mental status changes or the temperature crosses the 104 degree mark, you can save lives in the field. Here's another new page, and it's tailor-made for EMS and fire operations in hot weather environments, like the ones we encounter here in Arizona. The Emergency Operations Rehabilitation Guideline supports on-scene cooling, rehydration, and assessment of public safety personnel involved in firefighting, law enforcement, or other extended emergency operations. This guideline applies to fire, EMS, law enforcement, and other public safety personnel who experience heat illness or exertional symptoms during active emergency operations. It's intended for those who need a structural medical assessment to determine whether they're fit to safely continue their assigned duties. It's designed to help EMS safely monitor, treat, and release occupational responders who may develop heat-related symptoms while also identifying those who need escalation to ALS care or hospital transport. NFPA 1584 defines acceptable vitals for rehab release as follows: temperature below 100.6 degrees Fahrenheit, heart rate under 100, respiratory rate between 12 and 20, systolic blood pressure under 160 with diastolic under 100, and oxygen saturations over 94%. Here's how the process will work, broken down by time intervals. At first contact, begin with initial vital signs, oral hydration, and cooling. If vital signs are within NFPA parameters, the responder can be released. If not, have them rest and rehydrate for 20 minutes. At the 20-minute mark, recheck vitals. If they're now within NFPA parameters, you can release the patient. If they're still outside the acceptable range, escalate to ALS care and begin a patient care report. ALS providers should then start universal care as needed and obtain a 12-lead ECG. If it's abnormal, begin appropriate treatment and transport. If the ECG is normal or matches the patient's prior baseline, you can continue rehab and treatment for another 20 minutes. Treatment at this point could include a 20 milliliter per kilo IV fluid bolus for mild hypotension or tachycardia, as well as oxygen if the patient is hypoxic or has elevated carbon monoxide levels. Now at 40 minutes, perform a third set of vitals. If the responder now meets NFPA benchmarks, they may be released or cleared per your non-transport policy. If not, they should be transported. If you are using a carbon monoxide oximeter, follow this guidance for carboxyhemoglobin levels. Any patient with a carboxyhemoglobin level of 15% or higher needs to be transported regardless of symptoms. Hyperlinks to the carbon monoxide guideline are included in several places for your review. This guideline gives EMS a clear and defensible structure for on-scene rehab, data-driven return-to-duty decisions, and early identification of heat illness in our fellow responders. It's a critical tool during extended operations in Arizona's high-heat environment. This is another new page and another critically important addition, especially here in Arizona. Drowning is one of the leading causes of accidental death in children statewide, and also a major risk for adults in pools, canals, rivers, and lakes. This guidance gives us a consistent evidence-based approach to managing drowning emergencies in the field. The page starts by clearly defining what drowning means. According to international consensus, drowning is the process of respiratory impairment due to submersion or immersion in liquid. It doesn't matter whether the patient lives or dies, whether they show symptoms or not. The terms near drowning, wet drowning, and dry drowning are no longer used. They've been retired from clinical practice. This guideline applies to any drowning process regardless of severity. In the EMT section, your first priority is scene safety and rapid removal of the patient from the water. Start universal care and follow the ABC approach with airway coming first. Provide airway support as needed using the least invasive method, especially in pediatric patients where BLS level support may be enough. Administer oxygen to maintain an SpO2 of at least 94%. If the patient requires assisted ventilation, make sure to use a PEEP valve set to between 5 and 10 centimeters of water pressure if available. If the patient is in cardiac arrest, follow the appropriate algorithm for VFib, PEA, or asystole. Be sure to evaluate for possible spine injury, especially if the patient was diving or somehow involved in a boating incident, and apply spinal motion restriction if indicated. Consider hypothermia in all cold water submersion cases and begin passive rewarming by removing wet clothing and covering the patient, but avoid aggressive rewarming. Throughout care, monitor pulse oximetry continuously. For paramedics, be sure to establish IV or IO access and administer a fluid bolus if indicated. Escalate your airway management only when necessary and continue using PEEP support during ventilation. Begin continuous cardiac monitoring and capnography. If the patient has gastric distension or difficulty ventilating, consider placing a nasogastric or orogastric tube to decompress the stomach. This guideline applies to both adults and pediatric patients, and it reflects modern best practices in drowning care. It reinforces the primacy of oxygenation and ventilation, de-emphasizes outdated terminology, and gives EMS a reliable structure for managing one of the most time-sensitive emergencies we face. In a state like Arizona, where drowning is a year-round public health concern, this page brings timely and essential direction to the field. This next page is also new. It covers patients exposed to a conducted electrical weapon, more commonly referred to as a taser. This includes both direct contact stun and the more common distance discharge using barbed darts. Be sure to keep in mind that these calls often involve patients who are under the influence of drugs or alcohol, having an underlying medical or psychiatric condition, or who were engaged in a physical struggle that may have resulted in additional trauma. Avoid tunnel vision and treat accordingly. For EMTs, the approach begins with scene safety and initiation of universal care. Dart removal is permitted in the field as long as the probes are not embedded in a high-risk location. These could include the face, eyes, neck, hands, bones, groin, or spinal column, areas where removal could risk injury to nerves, blood vessels, or other important anatomy. If the darts are located in a safer site, such as the back, thigh, or abdomen, they can be carefully extracted. You should also assess the patient for signs of delirium with agitation. If present, refer to the agitated, combative, or violent patient guideline. These patients may become unstable very quickly and require sedation or other advanced interventions. If the patient suffered a fall, was physically restrained, or shows signs of traumatic injury, you can follow the general trauma management guideline as well. For paramedics, the additional steps are limited but important. Initiate continuous cardiac monitoring and consider a 12-lead ECG. This is especially important for patients who are altered, agitated, or have underlying cardiac risk factors. In most cases, taser exposure itself is not dangerous, but the surrounding circumstances, including intoxication, trauma, or agitation, can definitely introduce significant medical risk. This guideline helps structure that assessment while reinforcing safe dart removal and symptom monitoring. Here's another new page. It covers EMS care for patients exposed to riot control agents, including substances like tear gas, pepper spray, or other chemical crowd control irritants. These are typically oil-based compounds designed to incapacitate rather than injure, but they can still cause significant discomfort and complications, especially in confined spaces or in patients with pre-existing conditions. The guideline applies to agents such as CN, CS, or OC, commonly known as mace, tear gas, and pepper spray. These are classified as harassing or incapacitating agents and should not be confused with more dangerous chemical warfare agents like chlorine, ammonia, or phosgene gas. Now, if you suspect exposure to a substance intended to cause serious injury or death, make sure you are contacting the Regional Poison and Drug Information Center. All of the assessment and treatment steps included in this guideline fall under an EMT scope of practice and begin with removing the patient from the contaminated environment and initiating universal care. Once the patient is in fresh air, remove contaminated clothing, especially being careful around the face and head. Address any respiratory or breathing concerns first as needed. For eye decontamination, if the patient wears contact lenses, have them remove the lenses as soon as possible. Then consider washing the eye and face area with baby shampoo to break up the oils and making the water flush more effective. Then flush the eyes with fresh water for 10 to 15 minutes. Please note that Morgan lens devices should not be used for initial decontamination in this context. For body as well as the face, the guideline recommends first washing exposed skin with hand soap, shampoo, or dish soap, again to break down the oil-based irritants before rinsing. That way, when you flush with water, you don't spread the oil to other body areas. Finally, keep in mind that trauma may also be present, especially if the patient was struck at short range by a pressurized liquid stream or projectile during crowd control measures. If so, you can follow the general trauma management as indicated. This guideline helps ensure that even in challenging, high-tempo public safety situations, EMS has a consistent and safe approach to treating patients exposed to riot control agents. This page is new and it covers hydrocarbon poisoning, a low frequency but potentially fatal toxicologic emergency. Hydrocarbon exposures could involve ingestion, inhalation, or dermal contact with substances like gasoline, propane, paint thinners, or pine oil-based cleaners. These incidents may be accidental, particularly in children, or intentional, such as in cases of huffing. Signs and symptoms can vary. Central nervous system depression can occur rapidly, sometimes leading to seizures. Pulmonary effects can include chemical pneumonitis, especially if the hydrocarbon was aspirated. Cardiac effects are less common, but potentially the most dangerous. Patients may present with premature ventricular contractions, ventricular tachycardia, or even torsade. One critical caution: avoid the use of epinephrine or albuterol in these patients. Catecholamines can lower the threshold for lethal arrhythmias in the setting of hydrocarbon toxicity. This applies to both adults and pediatric patients. For EMTs, begin with scene safety and appropriate PPE, including SCBA if you are entering a confined or low oxygen environment. Safely remove the patient from the hazardous environment, start universal care, and apply continuous pulse oximetry monitoring. Next, administer high-flow oxygen via non-rebreather mask or BVM. If there are airway concerns, refer to the airway management guideline as needed. Next is a link to the seizure guideline, also if needed. You should try to confirm the substance involved, how much was ingested or inhaled, and how long the patient was exposed. If needed, contact the Regional Poison and Drug Information Center for advice or confirmation. For paramedics, initiate continuous cardiac and end-tidal CO2 monitoring and consider acquiring a 12-lead ECG. For a patient with ventricular dysrhythmias in the setting of huffing or other hydrocarbon exposure, the guideline authorizes the use of a medication called propranolol, but this is reserved for tox paramedics only. This page reinforces the importance of cardiac monitoring, caution with your medication choices, and early recognition of CNS and pulmonary toxicity. Hydrocarbon poisoning is rare, but when it happens, outcomes depend on rapid identification and avoiding interventions that could worsen the patient's condition. This is the final page in the toxicology and environmental section, and it covers methemoglobin toxicity. This condition is rare but potentially life-threatening, and it occurs when iron in hemoglobin is oxidized, impairing the blood's ability to carry oxygen, even when oxygen is being delivered properly to the lungs. The older YRMC guideline refers to this condition as methemoglobinemia and included both treatments and agent lists, but the Onvida version refines the presentation and focuses the treatment around field recognition and consultation. The hallmark sign is cyanosis that doesn't improve with oxygen. Mild to moderate cases may show cyanosis without any other symptoms, while severe cases can include chest pain, shortness of breath, altered mental status, or even seizures and coma. You may also hear the term chocolate cyanosis, referring to the classic appearance of chocolate brown blood on exposure to the air. Causative agents include amyl nitrite, isobutyl nitrite, sodium nitrite, topical or injected local anesthetics, nitrobenzene, and certain industrial dyes. Some of these agents, like amyl nitrite, may be present as part of a field treatment for cyanide or sulfide exposures, so this complication may occur after treatment of other medical conditions. For EMTs, begin with scene safety and initiate universal care. Administer high-flow oxygen via non-rebreather mask and start pulse oximetry monitoring. Be aware that pulse oximetry values may be unreliable in methemoglobinemia and may remain low despite oxygen therapy. You're going to be looking for the classic refractory hypoxia, where the pulse oximetry readings remain pegged at around 85% no matter how much oxygen you administer to the patient. If you suspect this condition, confirm the substance involved and call the Regional Poison and Drug Information Center for more guidance. For paramedics, initiate continuous cardiac as well as end-tidal CO2 monitoring and consider a 12-lead ECG, and then escalate airway management if needed. Make sure to treat hypotension with fluids or push-dose epinephrine if needed. We include the shock hyperlink here. In severe cases, the treatment of choice is methylene blue. This medication is restricted to tox paramedics only, and this new guideline does simplify the dose to 1 milligram per kilogram IV or IO over 5 minutes with a maximum dose of 100 milligrams. Importantly, methylene blue should not be given to patients with a known G6PD deficiency, as you may cause hemolysis. Compared to the older version, the Onvida guideline removes the routine repeat dose recommendations and instead places more emphasis on accurate recognition, appropriate antidote use, and medical oversight. The list of causative agents is shorter and more focused while still covering the major known sources of exposure. This brings us to the close of the toxicology and environmental section and to the end of this 7-episode training series. We've walked through high-frequency emergencies like opioid overdose and stimulant toxicity, as well as rare but high-stakes situations like radiation exposure and methemoglobinemia. We've covered changes in terminology, clarified antidote access, reviewed what's new, what's improved, and what's no longer recommended. Most importantly, we've grounded every page in the realities of field practice, whether you're working a triple-digit summer in Arizona, responding to a gas leak, or helping a colleague recover in the rehab sector. This concludes Part 7 of the Onvida Health EMS Guidelines video tutorial series. Thank you for watching.